recommendation to your colleagues?
So I think the challenges of disagreement and breakdown in the relationship with parents are actually, they're some of the hardest things that we have to deal with. In fact, the stress associated with that, I think, is much greater than the life and death decisions, though sometimes they're connected. Sometimes disagreement is related to decisions about end of life. I think the first thing that we have to do as professionals is to listen. So we need to understand where parents are coming from, what their understanding is, what their concerns are, because there are a couple of possibilities. So one is that we're right and they're wrong, but if we don't understand why they've come to a different view, then we have no chance of addressing that. We need to understand they have a different understanding of the facts, in which case maybe we get more tests, we get extra opinions, we try and help them to understand the relevant facts, the baby's chances, whether treatment will work. Or is it a question of values? Is it about what's important for them? Because if it's a question of values, then it doesn't matter how many facts or opinions that we get. We're not necessarily going to change the fundamental issue, which is that we and the parents are prioritizing different things. And if we are prioritizing different things, then we need to work out it is what the parents wanting, even if it's not our personal choice, what we would choose or recommend, is it something that's nevertheless reasonable, that we can support, that we can respect? Or is it something that actually we can't do and that we then need to work out a way together through this? Most disagreement can be resolved with time, but we also need to recognize that long-standing disagreements get more difficult with time, and that relationships can become increasingly strained. And some of the work done by Sarah Barkley and others focusing on early identification of communication breakdown suggests that if we can identify disagreement early and address it and open up communication, that it can prevent intractable and very damaging disagreements. And there are a range of resources that we can use. We can use our colleagues and peers. We can draw on wider members of the professional team, our psychologists, our chaplaincy team, social workers, depending on where you are. There's a range of different people to help support the family and to understand the family. Sometimes there are external support that can be helpful, like mediation can be particularly helpful. Sometimes clinical ethics or external second opinions. Very, very occasionally, it might be that actually the baby needs to be transferred to a different area because actually what is being asked for is not something that we can or are willing to provide, but somebody else is. So there are a range of different options, but this is very difficult. You asked about where there's disagreement between parents, and of course that becomes even more complicated where there's disagreements within families. I think sometimes our focus is on parents, but there's a wider family as well, and sometimes it's even more complicated when there are in-laws who are saying things that may be adding to the stress in parents, and they're feeling the need to they're being the in the middle between their family and the professionals. So I think we need to understand what it is that parents are experiencing, why they're feeling this way, and then we need to be able to support them in what is not only an extremely difficult situation because their child is extremely unwell, but also because they're now finding themselves opposed to the doctors for whatever reason. So I think we need to avoid the temptation to stigmatize or label the parents as difficult parents, as the troublemakers. We need to remember that most of us as health professionals would be a real pain if we had babies in the neonatal unit. We would be the difficult parents, though. Of course, we shouldn't use that term. And we need to support the parents and work together to find a way forward.
Thank you. You bring a very important issue also up. We had when we prepared this session, and we know that many people from all over the world today attend. There was a discussion if there is a difference between, I would say, parents in Germany compared to Spanish parents, or parents in India, or parents in Africa, or parents in I would say well-educated family, or a family which is in a developing country. And there was a big discussion in the preparation of, is there a difference how we should treat the parents and how we inform them and educate? And being a parent advocate, I already made the answer of no, of course not. Everyone should be, of course, informed and brought into this decision-making situation, in which, of course, level they understand. But I see me not different to a mom in India or a mom in Nigeria, wherever. This was my personal opinion, because being an advocate. But how do you see this as a professional, Dominique, or all the others? Is also a question to everyone, because we have so many different countries here represented.
Well, I think there are probably others who are better qualified than me, because I obviously only look after parents in one country, though I've worked in Australia and the UK. But I mean, I think there's two answers. One is all parents are different, and we shouldn't treat parents as the same. We need to meet them where they are in their individual situation with their baby, try and understand them, work together to care for the baby. But what it means to do that, I think, is different in different places. And that's partly because of the structure of the healthcare system. Partly it's because of the values that families will bring, the cultural values, the religious values that they will bring to those, and as well as the expectations of the culture. And I mean, I think, yes, there is an ideal model that we might have in our head about a shared care of the baby. And yes, it looks very different in parts of the world where there's still a very paternalistic, doctor-centric model. I'm inclined to think the first is what we should be aiming for. The latter is old-fashioned and we should move away from. But I think we also have to be realistic and recognize that that things aren't going to change overnight, either the health professionals or the parents themselves. So it's a constant process of trying to work together to improve our care for families and babies.
Yeah, thank you very much for giving.
Questions. The moment when I felt that I became, this is how I felt. I don't know if it was real or not, but the moment when they realized that I know what it means, 80% oxygen level in the respiratory machine, the moment when they realized that I have an ex-colleague within the nurses who I worked with within 4 years, that was the moment when I was thinking that that was the biggest mistake. That now they know that somehow I'm a little bit insider. So they have, the immediate discussion towards me became as to protect you. This is your interest. But I felt, and well, they took every written information away from the incubator. So from that moment, I could receive only oral information about my son. So maybe there are some kind of bad parents, or I don't know how to mention this, if they're coming from the healthcare professional side.
Can I just also add to Livia's comment that I've got a healthcare background, and my daughter's medical file had a sticker on the front of it saying Mum has a medical background, and it absolutely influenced the conversations that were had with me. I almost felt they were finger pointing at me as somebody not to talk too much to. And at one point, my daughter developed MRSA in the NICU. I hadn't been informed. I only discovered it when I arrived at the NICU to discover her incubator had been removed from the NICU, and naturally I thought she was dead and that they'd just forgotten to tell me. And when I was informed what was wrong, it was relayed to me that my daughter had methicillin-resistant Staphylococcus aureus. Now, you do not say that very long word to any parent. Now, I was able to retaliate and go, where did she get MRSA from? But I just felt, as Livia said, there shouldn't be a distinction as to, you know, we're parents, we're mums. Some of us may have a background that helps, you know, have conversations, but maybe it's difficult. Maybe with litigation these days, it's really hard and you have to be so careful. But the impact that it has on a parent when we feel singled out can be quite devastating, and it can actually ruin a relationship that you have, an emerging relationship that's got to go on for months and months with staff in that very small room. So it's a difficult one because it can be quite tense at the very best of times. But I guess if you can try and not to distinguish parents by their occupations and what level of knowledge they have, and try and treat us as parents. My daughter's neonatologist knew my medical background the day she met me, and she said to me, you know, in my eyes, you're just always going to be Amelia's mum. And that's how she spoke to me. And every single day, she was the only person that ever introduced herself by saying, how are you today? And then she would proceed to talk about Amelia, but she was the only person of our entire journey that saw me in the NICU, that I felt was seeing me as somebody who was important. So it is important, I think, to recognize parents for the role that they fulfill, because they have to leave that NICU and they have to take with them the skills that they've learned in that very unusual artificial setting to the home setting, and they have to do what you're doing. They have to be the parent. So it is really important that they're upskilled, and relationships that are damaged within that setting will damage how they learn as parents. So it is important, I think, to make that effort not to distinguish parents. And, you know, as was said earlier, if there are any disagreements, early resolution is absolutely the way forward.
That you are well educated or in a similar have a similar background, but it's also what we hear quite often when we have parents from social disadvantaged families or also foreigners, and that they are treated very badly or get less information because they understand anyway nothing. And so this is also something what I guess we parents also want to raise here, that it's up to you then to speak to us, that we can follow what you are telling us, and that you break down your medical Latin language in a way how we can understand you and see us as the parent of this child.
I had a question, Silke. So one of the things that we have parents from so many different cultures, just here in the UK, I mean, we have a huge population from Poland and Southampton, and clearly what we need to be able to do is to communicate with them as close to their culture and language as possible. And I just, one of my questions in those situations is, I mean, clearly translation is very important for parents who can't understand, but it's so difficult for me as a doctor to get the non-verbal communication skills to be able to speak to somebody from a different culture. And I would so much want to do that, because that's what I've learned to do. And that's the experience that I would give to parents who are from the UK. And is there any way we can learn, you know, is there anything that you would suggest as parents that we can do to try and personalize that conversation more? Dom has spoken about, you know, asking about babies, whether we can personalize by speaking about the baby's name, asking right at the start, but any other things that you, Olivia, or any of the other parents on the conversation that we're having at the moment would like to suggest for us in that regard?
Well, this is what we have tried with our project on the European Standards of Care for Newborn Health. We really have also one part where you as healthcare professionals should be also educated, not only in the medical issues, also in the way how to communicate. And you cannot communicate only with a language or with to speak. You speak with your body, or you also have this culture differences. And in many Muslim families, you speak mainly to the father, and all this kind of issues, or even when a baby is in this challenging situation of potentially passing away, what needs to be done and coordinated. And what we would like to have is that also your teams get a really proper training and be trained in communication with parents, I would say in general. And yes, we are all different, but also you are all different. Each of you are individual. If you come from India, from UK, Spain, German, many people say I'm not a typical German because I'm very, very open, very flexible, very, funny and so on. That often people say, are you coming from the south of Europe? No, I'm in many cases like a typical German. And so we are all different and individualized. And also this is what we want to be seen. And you even can ask parents, they are happy to also answer questions of what would be best for you, as Dominic said before, ask. And this is also something where we where this would help, because you cannot as a neonatologist understand each culture, each language, so therefore you have to do your best what you can. But we also recommend strongly, also in our standards, that you not only need a medical education and training, you need, because you work with us as patients and parents, you need to be trained in communication, in body language. And that people, when I was sitting and kangarooing, the doctors always were on, and I had always to look up to them. And so in the meanwhile, many doctors go down when I kangaroo and speak in this way. That is very simple. And but I had always the feeling when there were 5 doctors around me that I always had to look up. Simple things. And this had nothing to do with culture issue. It's really something of, on eye to speak together. So there are many things which generally works for every culture, but also when you have a lot of people from Poland or a lot of people from India, Pakistan, then I would recommend that you have colleagues in your team who are always coming from these countries who can train you. We in our EFCNI team, we have once a month a team training, the others train us. So you can also use this opportunity for your own team, that they train you in which kind of special things are for these cultures or these backgrounds. That helps also. It makes it cheaper, maybe, or even because it's also often a budget issue to finance this training. But this is something we definitely recommend, because you all are also just humans. Nobody, first of all, is perfect. You are also stressed. You are also in a work where you have a lot of shifts where you work. You are stressed. You work on weekends, and and everyone is just a human. Nobody's perfect. So this is also what we parents have to learn, that and this is what we transport also in our parent community, that we have to collaborate, we have to work together. Nobody's perfect. And so this would be one of my recommendations. I don't know what the other colleagues
Might
say.
I just add, Silke, that also when you do come across a situation where it is a learning experience for you, that you document it, so that not just you learn from it in your unit, that there is a living document exists within your unit in relation to different cultures that you come across, so that your colleagues who come after you in the future can actually refer to that. At least then you've got a living document, and it's growing and growing and growing, whether you continue to stay there or not.
Maybe I would just add a little, when we were speaking about, yes, the parents are different, and even the healthcare professionals also, just to, in the morning or in the evening when you start your shift, just think about when that mother or father is coming inside of the NICU. They have their own trauma, they have the preterm trauma, they have their own problems at home. They are dealing with a baby who they don't know that if they're going to survive or not. And then when they see the chart and to see who is in charge on that day, doctor or nurse, they have to carry that way also, that, okay, so today it's again, this is someone who is speaking, behaving, making gestures. So you're making life a little bit more difficult. And then this is how we are creating problematic parents also. And even in the other way, when we know that this is a really communicative doctor, really family friendly or patient friendly nurse, today it's going to be easy. Today I will get every information. So I would say that the whole atmosphere is changing, and it's about just to get into the NICU and looking to the chart. This is something I would say that, and from the other side also, it's really important.